This is a presentation about cardiopulmonary resuscitation. What we're going to talk about this evening is why CPR is important, and we're going to talk a little bit about survival rates. We're not going to worry about legal and community considerations. We'll talk about the chain of survival and when and how to administer CPR. So, starting with the start, what is a cardiac arrest? Now, cardiac arrest occurs when there's a sudden loss of blood to the heart and the heart stops pumping effectively. Now, that normally occurs through coronary artery disease, and that accounts for something like 70 or 80% of all cardiac arrests. Now, in Australia, year on year, you get about 33,000 cardiac arrests a year, and of those, about 10% survive. But of those 10%, and this is really interesting, this is statistics from the Victorian Ambulance Service, who do a they call a VACAR register, cardiac arrest register, and this is only Victoria, so it's not quite the same as the whole of Australia, but the rates are still the same. So 10% survival rate, but of that survival rate, only 37% are what they call a high use and survival rate, which means they live a normal life again. So that means 4 out of 10 people who have cardiac arrest who actually walk out of hospital, live a normal life. The other 6 have some sort of disability or adverse medical outcome from that. Now, these stats are really interesting because these are like directly taken from every cardiac arrest that occurs in Victoria. So you've got things like response times, 7.7 minutes, defibrillation times within 10 minutes, and the identified 87% of cardiac arrests were identified correctly by AAA call takers. So that's a pretty good record. That's a pretty high strike rate. So that shows that the algorithms they use are identifying the cardiac arrests correctly. Now, what's other interesting is 80% of bystander witness arrests were actually given CPR. So that's a really high number. It's the highest number ever. So that means that more and more people are learning CPR, are willing to use CPR and understand the importance of it. And a lot of that's to do with public access defibrillators as well, because people have a greater understanding of what defibrillators are. They're out there in the community, like every shopping centre has one, every airport has one, or many. Most sports clubs have them. So there is a really high rate of AEDs out there, which is terrific. This is a bit more information from the VACAR register. This talks about discharging a life from hospital. Okay, that's the most important one we're looking at. What's really interesting there is public places and medical facilities have the identical 29%. So that's pretty amazing when you think about it. So people who have arrested in a public place and have walked out of hospital have as much chance who arrested in a medical facility. You would have thought the medical facility would have been a lot higher, but it's maybe they're overthinking it perhaps in medical facilities. Private residence is very low, and that's probably more to do with people being older, being at home, and also definitely aged care facilities. That's why people have not for resuscitation orders and that type of thing. So it's not that they're being ignored, it's just that people in aged care facilities don't want to be resuscitated from a cardiac arrest. There's one other stat which is about response times, and that's just reinforces the 6 to 10 minutes or 7.7 minutes, which was their median. And you can see in metropolitan Melbourne, 60% of ambulances for a cardiac arrest arrive within 6 to 10 minutes, which is not bad going, really. Rural, 46%, which is probably more impressive given the distances they have to travel. Okay, the next thing we'll talk about is chain of survival. And this is the essence of cardiac pulmonary resuscitation, or doing resuscitation. The chain of survival is a globally recognised endeavour. It's recognised around the world. It has different variants. Some have 3 chains, some have 4, some have 5. But in Australia, we basically use the 4 chain of survival, so it's early access. And what that basically means is early recognition. Early recognition that someone's suffering cardiac arrest, getting onto CPR really quickly, and the research is now showing that the quicker you do CPR and the longer you do it for and without breaks before the ambulance gets there, the greater chance that person has of walking out of hospital with a high Houston survival rate. Early defib, if you've got one available, use it. Early advanced life support goes back to the primary survey of sending for help quickly. So if all those four things fall into place, you've got a really good chance of walking out of hospital alive if you suffer a cardiac arrest. So, what's the next one we'll talk about? So, talk about the chain of survival, early access, early CPR. I won't worry about doing the Vinnie Jones video. Early defib, early advanced life support. So we'll talk about the primary survey now. The primary survey is intrinsically linked with the chain of survival, okay? So when we come to any first aid situation, no matter what it is, car accident, person in distress, person running around crazily on the road, having a psychotic episode, no matter what it is, the first thing we have to think about is ourselves, and that's why D is number one, dangers, okay? Always look after yourself first and foremost. Your second responsibility is to the people around you. Third responsibility is to the patient, okay? Now you might sort of think, well, why should I bother about bystanders? But if you're aware of a situation that is dangerous and you've got other people moving into that situation, it's really inherent on you to warn them that don't go into that situation, it is dangerous. Okay, so that's why danger is number one. And dangers can be things like we just mentioned, traffic, dangerous people like assaults, snake bites, can be electrical faults, electrical wiring, poisonous gas, herbicides, anything like that. So the basic premise is if you see someone lying down or lying on the ground, you don't know if they're unconscious or not, you don't know what's going on, don't just rush up and just go, oh mate, what's wrong? You're okay. Just stop and have a look around, have a think about it. And think, what's going on here? Why is that person where they are? And that's even more important if you see two people lying on the ground unconscious, because that certainly suggests something more than a medical episode. Because normally cardiac arrests don't happen in pairs as a general rule. We've decided there's no dangers for us. The next thing we do is we check the responsiveness of the patient, and we do that by a simple shake and shout, and I'll just move into a couple of slides here. So shake and shout, something along those lines. I prefer to do it from the head end, but that's okay. We'll leave it at that at this point in time. So simple, can you hear me? Open your eyes, what's your name? That type of thing. If they don't respond, that's when you send for help, okay? Straight on the phone, 000, call them, verify your address, put the phone on loudspeaker, put it next to you, start dealing with the patient, because they will help you through any situation. They're really good at it. So never ever not call 000 in a time of emergency, because there's this multi-million-dollar things set up just for these calls. So make sure you use them. So once we've sent for help, this is where, if we know there's a defibrillator around, or we have someone who knows there's a defibrillator around, that's when you go and get it, okay? General rule, if you're by yourself, if you know it's easily accessible, close by, and you can go and get it very quickly, and you know you can get to it, so it's not in a locked cupboard, or it's not behind a locked door, go and get it very quickly. Much better if you're with someone, send them to get it, much, much better. And I think these days the 000 actually have a map of where public access defibrillators are, and they might be able to point you in the direction of one. But really, it's inherent on you as the number one rescuer, the person who's going to do CPR, to stay with the patient. But if you have to go and get one, so an arrest happened right here, and we had to go next door to get one up to the RSL, for example, I would go and get it, because it's worth it. For the 1 minute it takes me to go up and back and get it, that's more, it's more important for the patient's well-being overall to have the defibrillator here than not. But if someone can go and get it for me, that's much better, much, much better.
Defibs, you know how fire extinguishers were always in a situation, they might have been behind glass or something, you had to whack and you could get it out. Are defibs ever in those kind of locations? You talked about a locked door or something.
They're always in a case of some description, normally in a glass and metal box, but normally they're not locked. Depends where they are. Like in shopping centres, they're in those boxes, you can just open the box and get it out. Like I was in the country recently and they just had one on, there was one outside the pub and there was one outside the bowling club, just on a little bracket. Just grab it. But of course no one did. It was country, it was safe, and how good would it be if we were able to do that and just leave them in safe spots.
Access to everybody rather than potentially behind a locked door or whatever.
Well, they have to be locked away because they'll get nicked and misused and wrecked and all the rest of it. They're too expensive to be treated like that. But normally if you're in a shopping centre and someone has a cardiac arrest, you'll be able to get to it. They're not locked within those boxes, they're just open, but obviously if it's after hours you can't get to it. Okay, so the next thing we do, we've sent for help, got help on the way, we check the airway. And we do a very simple, tilt the head back, open the mouth, have a look. If there's nothing in there, continue on to the breathing. If there is something, you can use the recovery position. And that top left photo there demonstrates someone being put in a recovery position. I don't know if you're familiar with it. It's very simple. Arm out, arm across the shoulder, leg up, push, and just roll over. It's very simple. Even a child can move a big adult if you do it right, because you like create a film effect. Just roll the person over. When you've rolled them over into the recovery position, any fluids can drain out. You can clear it with finger sweeps if there's like foreign objects, or you can use a pen or something of that nature if you don't want to put your fingers in someone's mouth, which is totally understandable. And that little diagram at the bottom there just demonstrates how the head tilt opens up pulls the tongue away from the back of the throat and just opens up the airway there. Breathing. Breathing is a very simple matter of look, listen and feel. You'll be able to tell very quickly. Now breathing, we talk about in first aid, unconscious and not breathing normally. So breathing normally is what we're doing right now. If someone's breathing like once every 15 to 20 seconds, that's not normal breathing. If someone's doing agonal breaths like that, or gasping, that's not normal breathing. If someone's having an asthma attack, that's not normal breathing. If someone's choking, that's not normal breathing. So just take all those things into consideration and just think, if they're not breathing normally, I'm doing CPR because it's cardiac arrest until proven otherwise. And if you know someone's choked, or you know someone's had an asthma attack but now they're unconscious and not breathing normally, you still do CPR. There's nothing changes. That's the way that's what the primary survey is all about, is reverting back to it. So you find it, whenever someone becomes unconscious, not breathing, just straight back in. Find your spot and away you go. So if breathing is not normal, you start CPR. Now CPR is a simple matter of making a V or a wedge shape with your arms and your hands. Heel of your hand and the centre of the chest between the nipples is the most important, the easiest place to do it, and it's the right place to do it. CPR is one of those things is the right way to do it, which is the easiest way, and every other way that people try and do it is wrong and it's harder. So if you do it the right way, it's actually the easiest way. So you make your heel of your hand, you can either interlace your fingers, you can just one hand on top of the other, which is what I prefer to do. Then you just hands in the centre of the chest, as demonstrated there. Then basically bending from the waist, you do 30 compressions at the rate of around about 100 per minute, which is quite fast. Now for infants, which is demonstrated on the right hand side there, it's 2 fingers. So the only difference with adults and infants is when you do the breaths. I'm not sure what the breaths are in here. Just compressions, no. Breaths are a bit out of vogue at the moment because of COVID, so people are steering away from them. But quite simply, if you decide you're going to do breaths, you do 30 compressions. When you finish the 30 compressions, you pinch the person's nose, tilt their head back, lift their chin up and just breathe into their mouth twice. For an infant, the only difference is you don't tilt the head, you keep the head nice and lined up because their airways are a lot smaller and they occlude really easily. So important for an infant to keep them nice and level, and that might involve putting a little tea towel or a cloth under their back because their heads are so big. Their heads tend to push their neck forward. But for an infant, it's 2 fingers, centre of the chest, exact same rate, exact same spot, relative. For an adult, it's 2 hands, and for a child, depending on the size of the child, it might be 1 hand. So for a child, say between the ages of 1 and 6 to 8, 1-handed CPR. And then once you get to a bigger child, you go to 2-handed CPR. All you're really trying to do is about 1/3 of the depth of the chest. So it's all relative. So if someone's got a big chest, 1/3 might be 6 to 8 centimetres. For a child, it might be an infant, it's like 1 to 2 centimetres. So it's all relative. And that's why, by doing it like that, you can't really push too hard with 2 fingers. But with 2 hands, you sure could. So you do it for 2 minutes and then swap around if you've got another operator or another rescuer, which is obviously much more beneficial if you do. That's just to reiterate the chest compressions, 30 compressions, 2 breaths, centre of the chest, 1/3 of the depth of the chest, rate of around 100 to 120 per minute, and switch rescuers. Now the defibrillator is important because it will shock the heart out of the rhythm that we don't want it to be, frankly. And that's a defibrillator, so just a Zoll. There's dozens of brands out there, they're all different, but they all pretty much do the exact same thing. Most of them have a case that opens like that. When you open it, it'll start talking to you. It'll say, pull open pads, and the pads are in a sealed foil case, like a ripcord. Place pads on chest, make sure chest is clean, place pads on chest, remain calm, da da da. And it'll take you all the way through. So once you've got the defibrillator, you can put your brain in a box, you don't need it anymore, you just follow the instructions. Now they're really good too because they light up and they also beep. So if your numeracy is not good and you're not good at counting, you can just rely on the beep, 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 beep. And you can also has drawings, so if your English is not great, it's all done with diagrams as well, so you don't really need to worry about any of those things. They're universal. Now what happens, that's a normal heart, and those lighted up bits there are the sinus node, the AV node, and what happens in a normal heart rate, the sinus node will fire, then the AV node will fire, electricity runs down the middle and then up the left side and up the right side at the same time, okay? So then you get the effect of the boom, 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 like that. And that produces, if you put that on an ECG, that's what you'll get, a normal heart rate. Perfect QRS rhythm there, so you can see it's nice and even space. It's about rate of about 60 to 80 per minute. It's got P waves, it's got T waves, everything's perfect, and that's a classic perfect QRS normal sinus rhythm. Now when they go wild, this is where the defibrillator comes in, because you get that, and that is called shockable ventricular fibrillation. And as you can see, it's compared to the other one, it's bizarre, it's chaotic, there's no recognisable complexes in it. And what will happen over time, they'll become finer and finer until it eventually goes into asystole, which is that one there.
Flatline.
Flatline. But there's another one called ventricular tachycardia or pulseless VT. Super fast, it sort of has a rhythm, but it's very broad and it's very complex. Complex meaning really up and down. And it's going at about 240 beats a minute, unsustainable, and that will certainly not compatible with life. So what the idea is, by using the AED, the machine will recognise one of those two rhythms, either pulseless ventricular tachycardia or pulseless ventricular fibrillation. It will say shock, it will deliver a shock, it will bring you back to that. So it just knocks all the electrical activity out of the heart. Then we go back to the diagram of the heart, and there's a line under there that says intrinsic pacemaker cells. These cells have properties known as automaticity. Means they can spontaneously depolarize, which means they can spontaneously fire. With a little bit of help from some CPR, your heart can start on its own, okay? It doesn't need a command from a muscle or a nerve or a hormonal impulse, it will just start. And if you're lucky enough, the first shock with some CPR will shock it back into something akin to that, which is normal sinus rhythm. But what will normally happen is that it'll be a bit funky because there's been some damage to the heart because of the cardiac arrest. So instead of being a perfect like beep, 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 it might go flick off, or it might go below the line, or there might be longer pauses. And that just means that the electroactivity is trying to find its way through the heart, and it's losing its way because there's dead tissue, basically, and it can't find its way anymore. So that's where the job of stents comes in to the heart will eventually grow arteries. It does that on its own, but it takes time. You have to get someone in to get a stent put in, or maybe open heart surgery, depends what's gone wrong with them. The idea is, so you might have, and then it might revert back into VF again, then you shock again, and back into hopefully QRS again, and it might go back again, and then this can keep happening and happening. until I eventually stabilise the heart, and that normally takes drugs. The microparamedics they carry a lot of different medications that are purely just for the heart. So that's pretty much how it goes. The summary, importance of high quality chest compressions, the DRS ABCD, and if you can do CPR, you can save a life. That's pretty much it. Any questions?
Will the AED, like if you were in a situation, I don't know if this would ever happen, that you kept going, is the thing got a battery life that's going to conk out?
It does, but it doesn't conk out. I think I actually looked this up. Someone asked me the same question recently, and the one I looked up had the ability to shock between 150 and 300 times.
Wow, that's a lot.
So the thing is, the joules, it works in joules, and joules is really low voltage, like it's really low. It sounds like 300 joules. Oh man, that's heaps. It's not. It's nothing. Like in terms of, I don't understand electricity, but there's volts, watts, joules, all the rest of it. I don't really understand. My understanding is joules is something that can be like sent out, like through the pads. You don't send volts out through pads. You can send the joules out. So it must be a way of. I don't know, but that's what this. So it's a lithium battery which lasts about 5 years, I think, and it'll shock up to 300 times.
So I assume these devices get checked.
Yeah, they get serviced. Yeah. So well, that's interesting because people have private ownership of them. It's up to them to get them checked.
So one hopes.
Yeah, so one hopes they get
They've
checked.
forgotten about it. Oh, good.
Like when I was with the ambulance service and we did logistics, we had to upgrade all these Philips ones because they had a problem. These were the big monitors, not the little baby ones. And so I was going there, like getting 20 at a time from Philips, which were used to then replace ones in the field, which you then bring in, get them upgraded. Then they go out as replacements for another 20, and we're doing that all around the state. There's about 2,300 defibrillators or something. A lot that had to be upgraded. It was a huge job.
So is there a central audit on those? I mean, you said there's probably.
No, that was talked about. When I was still AV, we were sort of loosely tasked with the idea because we have what's called the locations of interest, people who frequent callers, that type of thing, violent people, those sort of offenders. So someone said, they do that, they can do this as well. And my boss, rightly so, said, how are we going to do this? How can you manage it? We don't know who's got what. We don't know when they're available. How are we supposed to, like, may create this great big database that has every defibrillator in Victoria in it. Then the first time someone goes to use it, it's in a cricket club down at Lunston Street. Oh, it's not open on Tuesdays. Can't get to it.
Yeah.
And then there's this big hue and cry, oh, they told us it was there, and it wasn't there, and we couldn't.
But I
use
guess that would lead it then on to someone being responsible for getting all that information and creating a database that had, I mean, and I'm not saying that's
it's impossible. It's such a massive task. There would probably be tens of thousands of them in Victoria alone. It's just too big. Like AV, I know, what do you call it? Esther now have a database of some. I don't know if it's all, but they have a database of some. And they know what happens is when they look at the map of where you are, they light up. So they can tell you there's a defibrillator at the RSL, for example. Yeah. Whether they've got the one on there, I don't know. But the big problem was the privately owned ones. And Tony, like, he was an arsehole in a lot of ways, but he was good in that way. He sort of said, well, what if someone uses it, for example, and doesn't replace the pads?
Yeah.
Who's responsible for that?
Yeah.
You just can't.
No, I know. You sort of feel like there should be a way to do it, but I get it's got all these inherent.
What sort of percentage of cases are defibrillators actually used in as a percentage?
In cardiac arrest?
Yeah.
I think